The broadcast is now starting. All attendees are in listen-only mode.
Hi, good morning, everybody. My name is AJ, and I'm the publisher here at AI Meds. And we've got a really good presentation for you today. And we're going to be looking at the uses of clinical AI within identifying and addressing patient risk and improving population health across communities. Now, just a couple of housekeeping points. So if you do have any trouble, like you're not able to see anything, you can't hear us, please pop a question in this question box, and I'll do what I can to help you out and try and get that sorted for you. Also, we will be doing or getting around to answering all your questions at the end of the presentation, but please don't mean to leave your questions till the end. Please feel free to kind of pop them in as you're going, as when they come to mind. Now, if we aren't able to get to your questions during the kind of normal time for the event, we will be sending out personal emails to everybody to kind of follow up and make sure that you do get an answer for your question. Now, this is essentially why you're here. So we have our speakers today, as you can see. Our first speaker is Dr. John Showalter, and John is the Chief Product Officer with Jvion. And we have ShiSh Shridhar, who's the Global Strategy Director for Microsoft. Now, Dr. Showalter uses his unique education in biomedical engineering, physiology, and clinical informatics and internal medicine to really drive a positive impact for healthcare organizations and patients by leveraging Jvion's AI. And ShiSh brings a very different but valuable set of skills to the table. And his background is in geospatial analytics and Internet of Things. And this really allows him to help organizations to solve challenges with a very unique blend of technology and business acumen. So without any further ado, over to you, John.
Thank you, AJ, for such a nice introduction. ShiSh and I are excited to talk you guys through AI and visualization and using COVID-19 as a case example. So let's jump right in. Jvion is a clinical AI company. We're focused on preventable harm. We've got over 40 clients and been at this for about 10 years, and really do have methodology that lets us figure out what the next best step is for our patients and clients. But why AI and why now? It's because the data is getting so diverse. We're frustrated with legacy systems. There's all kinds of Internet of Things. There's geospatial data. There's just more data than the human mind can really comprehend. So we need to lean on artificial intelligence, computer science, visualizations to really understand all of the data that's out there. Huge market growth is projected for AI, as you guys all know. Projected to reach $36 billion by 2025. Oops, a little delay on advancing the slides here. We go back. The market is investing across different ways: homegrown AI solutions, analytics platforms, AI as infrastructure. And then as purpose-built AI vendors. We're going to really be talking about some purpose-built solutions today, but as well as the other AI techniques that you can use on homegrown solutions or on platforms. And it's going to cover a whole bunch real quick. You've got random forest, XGBoost, but tree decision-making algorithms have been a real bread and butter in clinical decision-making for a long time. They allow you to understand how the decision was made, much less black box algorithms. Linear regression, used at an advanced stage with multiple inputs, certainly requires higher compute, but has been around for a very long time. Logistics and linear regression have been staples in statistics for a long time. Also, pretty well understood. But some difficulties in there with bias and really understanding what the underlying driver is as you use a reduction model. So if you are using techniques to go from 300 variables to 20 variables, the risk of interjecting bias in those 20 variables becomes much higher. Getting into more modern AI with neural networks, especially convolutional neural networks. Convolutional neural networks are probably the most commonly used AI technique in healthcare because of their use in imaging. Almost all CT scan, echocardiogram AI is based around a convolutional neural network. Definitely all of the FDA approved algorithms are based on neural networks. And then Postman modeling, multi-dimensional space modeling, certainly is coming out as higher compute. If you guys look at, the studies on deep computing, they really spiked around 2016 when access to cloud-based compute became much more accessible to researchers. And we've progressed now from statistics to machine learning to then really multiple dimensional techniques into AI. And the techniques we're going to be talking about today from the Jvion side are n-dimensional techniques, looking at over 5,000 dimensions, a quadrillion calculations to make an insight. So we were definitely in the age of high computational demand and the need for access to the right resources to do that kind of analysis. But regardless of your analysis, one of the issues that you have to worry about is what we refer to as the accurate fallacy. And really the accuracy fallacy comes frequently in healthcare and frequently in rare conditions. When the most accurate algorithm is to say that something is never going to happen, you have a problem. So if you're looking at a rare event like congenital heart defects and screening of mothers to determine if there's going to be a congenital heart defect, that's an ultra rare condition, and almost all machine learning approaches are going to bring you to nobody has the event as the highest accuracy model. It's a completely useless model, it has no impact. So to us, the predictive analytics fallacy is a comparison of accuracy versus impact and a focus on developing impact. If you want to focus on impact, you have to be willing to use techniques that dive deeper into the population. And back to the analogy, the example with congenital heart defects, if you have 2 out of 1,000 congenital heart defects and you can capture one of those with 10 positives, then you have an algorithm that's potentially 50% effective. If you can capture both of them in 50, then you have an algorithm that could have 100% positive impact, even though it only has about a 95% accuracy. So you really want to look at whether or not your techniques allow you to focus on accuracy and impact. And some of the difficulties with linear regression, random forest, and neural networks is they really are honed towards accuracy, and it's much more difficult to hone them towards impact. But with a multi-dimensional technique, especially with a self-learning multi-dimensional technique and lots of data, you are able to begin to focus on impact. And that's the intent of the Jvion core, is to focus on impact. So if you're looking for mortality from something like COVID-19 in the general population, where the current estimates are ranging between 0.6% and 2% mortality, depending on how you calculate, whether or not someone has been infected, and then only 20% of the population has been infected, and you're looking at trying to determine mortality events at a 0.1%. You're in an area of rare predictions, and you have to be really careful about how you run your algorithms. There's just a paper out that looked at 50 cases and was predicting outcomes on those 50 cases and had some pretty funky predictors that they said were drivers. Now, is that because COVID-19 is unique, or is that because the technique was focused on accuracy? We don't know. We're going to have more data to find that out. But really, looking at the types of techniques that you use really affects whether or not you're going to have a positive clinical impact. That difference between accuracy and impact really gets to predictive versus prescriptive analytics. So predictive analytics focus on, what is the highest level of prediction that I can get. They tend to not be that accurate, especially historically. Moore's, Braden, source criteria very much drive alert fatigue, are very sensitive but not very specific. Whereas when you want to get into prescriptive analytics and you want to focus on having impact and reducing harm, you want to use the techniques that have a good specificity, a good sensitivity, but a higher level of specificity, and an understanding of what was driving those risks, so you know how to change the individual's trajectory. So the technique that we'll be talking about today from Jvion is a technique that uses multi-dimensions to calculate a patient's trajectory towards a bad outcome. So are they headed towards a bad outcome, and how fast are they headed towards that bad outcome? And then an understanding of the drivers, is that because of their immobility? Is it because of their chronic disease status? Is it because of their age? Is it because of their food access at home? Is it because of their lifestyle at home? What are those drivers, and what can you do about preventing an event once you understand those drivers? And taking actions to change the patient's trajectory. So what are the next best actions to mathematically push that patient away from headed towards a pressure injury to heading towards a safer area in that multidimensional space? So what happens when you use this in practice? So if you use this in practice and look at patients headed towards a hospitalization or an ER visit, you are able to have really big impacts and reductions. So this is an example from one of our clients looking at their employee population. They had a 30% reduction in the overall cost of their patient population. They reduced ER visits by 245. They reduced their inpatient visits by 377 and had a cumulative cost savings of 3.2 million. And in a employee population, that $3 million cost savings goes directly to the bottom line of that self-employed health plan. But it really is dependent upon, again, focusing on impact, focusing on where patients are going, and how to get them on a better trajectory. So that translates to COVID-19 by looking at previous pandemics. So our analysis, we assumed there was going to be a high rate of exposure. We assumed the data on exposure was going to be poor, so that the testing was going to be not done the same in every state and every county, that testing penetration was going to be limited. So we focused on bad outcomes. What do we know from the H1N1 pandemic? What do we know from the flu and other respiratory conditions? And what do we know about patients being hospitalized and developing sepsis? We know that they all progress through the same trajectory. There's community exposure to initial symptoms, bad enough that you present to the ED, sick enough that you're hospitalized, developing respiratory complications, other end organ damage, and then unfortunately, also death. So knowing that we were able to calculate the trajectory for those other conditions, we were able to create a parallel and have a surrogate for COVID-19, do predictions at the community level to help with public planning and community response, and also to predict at the individual level. Why did we think the community was so important? Well, after H1N1, there was a very clear problem with disparities. So there was disparities in exposure, there was disparities in susceptibility, and there were disparities in treatment. All of those multiple effects added up to a 3 times higher mortality for the lowest 20% socioeconomically in H1N1. So we wanted to put a community analysis out there that allowed people to help tackle the COVID-19 issues, help with public planning, But additionally, we also took that knowledge and focused down to the patient level. So for our current clients where we have medical histories, laboratory data, medications and orders, we were able to develop risk lists and provide to our clients, excuse me, a rank list of all of their active patients with this is your patient most at risk of being hospitalized or death if they become infected with COVID-19. This is your second one, and the whole way down through the list. The community level insights and the patient level lists are already being delivered to the public and to our clients. We're also working with our clients on a real-time patient triage assistance, understanding who's going to need ventilators, understanding who's at risk for mortality in the hospital, but really want to focus on the community aspects. And this is where I want to hand it over to ShiSh, because after we did all of our data science and understood what the communities were, we needed a way to communicate this out to the public, and we partnered with Azure and Azure Maps to get that done. So ShiSh, take it away.
Thank you, John. And good morning, good afternoon, everyone, depending on where you're joining from. Thank you for taking the time for joining us on this webinar with Jvion. I'm ShiSh. I'm the lead market development manager for Azure Maps within Microsoft. So I'm part of the Azure IoT team. So I'll spend the next few minutes really talking about how a mapping platform like Azure Maps helps better understanding the impact of epidemics. Moving on. So before I begin, I just wanted to really talk about what Azure Maps at a high level is about. So it's a platform really for geospatial analytics. And what it really allows is it allows all kinds of location intelligence capabilities for applications. So within Microsoft, we have capabilities for doing all kinds of data analysis, for ingesting the data, storing the data, analyzing the data with AI capabilities, IoT capabilities, and so on. And the one element that provides the location of spatial intelligence is Azure Maps. So Azure Maps has got a whole lot of capabilities, including the ability to render maps, whether it is satellite imagery or standard imagery. In addition to that, the ability to also do spatial analysis, be able to figure out within a certain area, within a 5-minute zone of a hospital or of a certain area, what are the medical facilities and hospitals available, for instance, or what's the demographic mix of a certain area? What's the distance to the closest hospital? So any kind of spatial analysis. It also includes information on mobility, transportation available between points, the weather in certain areas, all of that as well. So it is really enabling all of that spatial capabilities and enables spatial capabilities for applications. One of the things I also wanted to start off with is John Snow is regarded as one of the early pioneers of modern epidemiology. And during the major cholera epidemic of 1854 in London, he collected and mapped data on locations. And this was really the street addresses where cholera deaths occurred. His process was generally very laborious and slow, but ultimately very informative. And then the painstaking detailed analysis really led to determining the source, the contaminated public water source. So mapping has really been, from that point onwards, it's really been a way in which you could analyze the patterns, you could analyze the spread, you could analyze where exactly the impact is. And in addition to that, looking at maps, you could also do analysis of demographics. What are the demographics around that area? What's the population like in a certain area? What's the flow of people? So really understanding those movements, the patterns, and the spatial understanding gives you a lot of insights. And that was one of the reasons why mapping became a very important tool in the analysis of diseases. Oops, I moved too many. Moving back. So why use maps? One of the ways I look at mapping platforms is like an Excel spreadsheet for spatial data. So you have a canvas with which you can do all kinds of analysis. You can load your data to. You can, in addition to that, you can start analyzing, visualizing that data as well. So in cases where you have data available from multiple sources, you could have data for demographics available. You could have data on the spread of disease available. You could have the timing of it available as well. So really understanding the patterns of that data, the correlations between the different entities like demographics and the spread, the time of year, the weather, all of that gives you really interesting insights. So the ability to just store, record that information is one aspect. The other aspect is looking for the interesting spatial patterns, the correlations between how did weather affect the spread in a certain area, or how did the demographics, is that an influencer, and so on, and the travel patterns. So there's multiple data sets that you can actually pull in and analyze and understand those patterns as well, also through visualization. The other aspect of it is using the mapping platform to really communicate the findings, to do the reporting after doing the analysis. And this is really what we've seen even during the COVID-19 situation now. Many of our customers are using the mapping platform for gathering data, understanding the patterns, communicating their findings, and doing the reporting on it as well. The other aspect also is the spatial analysis. So there's many capabilities with Azure Maps. One of the aspects is understanding a certain area. So within a zone on a map, within a certain area on a map, you can start loading a lot of data. Like, for example, you can start loading the demographics onto the map. You can load any other history information. You can load weather data. And any other influencers. And once you do that, you can define what's called an isochrone, a polygon around that area, which could be measured by a 20-minute zone, a 20-minute walk, a drive, and so on. And once you do that, you can find things within that zone. You can find how close are people within that area to medical facilities, to hospitals. What's the demographic mix in the area? Find high-risk populations in the area, and so on. And those kind of spatial analysis enables organizations to really define where exactly should we deploy facilities, where should we look at that areas that need medical attention of facilities or hospitals, and so on. When you analyze it spatially, you can tell how far away are people from medical facilities, where are the high-risk populations, and so on. The other very interesting thing with Azure Maps is there is disasters happening around the world that killed thousands of people, displaced millions of people, and a lot of times first responders need to have information to be able to find people, to be able to make decisions on where exactly they need to deploy relief efforts. So another really important area where mapping comes in is really creating those maps, creating maps for areas that were never really mapped before. There's a lot of interesting initiatives out there. One of them is really the Missing Maps project, which is sort of a volunteer effort that includes the Red Cross. where volunteers can go in and find areas that are populated on a satellite imagery and mark it out as populated areas and so on. And this process of creating the maps is really an important process as well for relief efforts and so on. The other really interesting area for understanding epidemics and disease and all that is really the, let me move to the next slide, is really the mobility data, really understanding movements of people in different areas. And this really enables understanding how the spread of disease happens. One aspect of it is using mapping technology to look at demographic data, the distribution of population, and also the mobility of people. How do they move? What's the travel patterns like? This information can be gathered from multiple sources. All of the travel information available out there, the historic travel information, where do people move around? What are the traffic like in certain airports? What do they connect to? And then, of course, the mobility within cities itself gives you an understanding of how disease can spread through that mobility. There was a really interesting experiment that was done with Azure Maps by one of our partners called Unicast, where they looked at movement of people. And today, all of us are in isolation and quarantine. I'm working from home, for example. And what's the impact of physical or social distancing on COVID-19? And that's another aspect of where the mobility data, as well as the spread data, when you start correlating it, gives you an indicator. Is the spread increasing where when people are congregating in big groups? Is it decreasing? Is there really an impact from physical distancing or not? So that can be determined by really looking at heat maps across the city, where you can actually see concentrations of people in certain areas in the city. And this is really anonymized, aggregated data where you see a heat map wherever there's a crowd of people on a map. And you can also see the correlated data for that city to say, do we see an increase or a decrease in the confirmed cases? And that was one of the experiments that was done. If I go to the next slide, let me do that. Yep. So this is an example of how the analysis was done by Unicast, where they're looking at the social distancing index for different counties around the US for COVID-19. Also looking at change in distance traveled, so they can actually see, are people traveling less or not, and then is there areas in the city where there is concentrations of people, and this gives an indicator. And then when you start correlating this to the spread of disease, you can tell, is there an impact to physical or social distancing? So again, another way of analyzing that data on a map. It all goes back to the point that I made, that Azure Maps is, you can think of it as the Excel spreadsheet for location data. So when you have a lot of data that you want to analyze, and it's got a location element to it, and when you load it into a map, you can start analyzing the patterns from a spatial perspective. What is the demographics in an area? How does that correlate to it? What is the movement patterns in an area? What's the weather in an area, and so on? All of those patterns and the spatial element to it that gives it context. If you look at this chart, one of the things that points that I'm making here really is that all of that location data that you're collecting, information about the spread and so on, and then when you combine it with mapping data, the mapping data actually gives you information about the physical locations, and then it allows you to correlate those locations with different data sets, the weather for that data, the demographics for that data, the spread information for that data, and so on. And then when you combine that with inference models using AI, you start getting really good insights that help you make decisions. And that's, again, how mapping platforms can be best used for doing the analysis. Whoops, I've skipped a slide. Let me go back. While it's loading it, I'll talk about that. It's actually on one slide forward, but what we did is we also released a dashboard to help healthcare agencies analyze the spread of disease, specifically for COVID-19. So this is a open source project that we did, and what you're looking at right now is an example of the dashboard that was actually modified and updated by a partner, but anyone can download this from GitHub. I've got the link in the deck, and once you have this, you can load your own data sets, your own KPIs, and use it for quickly analyzing patterns, communicating your findings, and using it for reporting as well. Here it is. So this was really the information about the open source project that we have available. This is a quick demo of what we have, but you can also load your own data sets. You can also load your own KPIs into this. And with that, I'll pass it back to John.
So we're really excited about the combination of combining the geospatial visualization through Azure Maps with the AI insights that we're able to produce. We started this with social determinants of health, and we published a paper in the American Journal of Managed Care in January on the ability to use the social, economic, and behavioral data available on people to predict hospital utilization, both avoidable admissions as well as admissions and all-cause admissions and ER visits. And why would you want to combine this with Azure Maps? Because it provides an understanding of both individual needs and resulting community resources. As you can see here, you're able to understand descriptively the income of a census tract, and actually this is the income of one of our clients' patient populations in that census tract. You're able to pull points of interest and where the grocery stores are, where the pharmacies are, where the health systems are, where kind of begin to get really decent insights from the visual. You're able to understand a patient's risk across, multiple risk factors, hundreds of social economic. Get census tract. You actually even see block level visibility for the 19 data that will show you, and really begin to understand, what are from a visual perspective, what are the challenges of this census tract. And then by applying AI on top of it, you can actually dig into the relative importance. So these are actual real zip codes that we've analyzed. And you can see that, in zip code 1, household income seems to be pretty straightforward across all of the census tracts, but the actual use of food stamps is a risk factor in the 2600 census tract. If you dig down to zip code 2, you'll see that the census tracts really don't look like the zip code that much. You've got 2 census tracts where household income is contributing a lot to utilization risk. 3, again, those 2 same zip codes that are, food access are a driving factor, and a couple zip codes where, housing stability, resident length is actually an increased driving factor of risk. So you're able to profile something like in zip code 2, the 1100 census tract, and say, wow, our risk is really being driven by the food access, the household income, and the housing stability for those patients. And we've got 194 patients in that zip code. But the nice thing about multidimensional techniques is that you can do a complete spectrum analysis. So you're able to look at the risk of every individual and draw a cutoff. So if we look at those that are truly at risk for utilization, you'll see in that census tract 1100, there's 144 out of that 195 that are at elevated risk for utilization, and they're actually on average in the 85th percentile of risk. And it looks like they have social support based on the number of adults in their household, but again, being driven by income, food access, and housing stability, and you can come up with a plan for those 144 individuals. You can actually dig into those 144 and start slicing and dicing by chronic diseases, populations of interest, to get down to a very actionable subset without ever having to actually query the patients for information. This work, the ability to do this in-depth analysis without talking to the patients, translated really well to our work for COVID-19, where we generated a COVID-19 vulnerability map. This is publicly available. Please do use it to help with your community planning. It's covid19.jvion.com. It is a national map, but you can drill down into counties, census tracts, block groups, information. And once you're zoomed into the local area, you're going to see block groups. If you zoom in far enough, you're going to see those points of interest again with regard to transportation, food access, access to hospitals and pharmacies. And the intention for this is really for people to be able to prioritize their outreach, prioritize their community planning. If you're in LA, I think there's 8,000 block groups, so trying to come up with a plan for all of those is going to be very difficult. But you want to be able to drill into those that are highest risk and make sure that you have an appropriate plan for your highest risk groups. I saw there was a question in the chat box about some of these risks. From H1N1, it was the bottom 20%, so those that had the highest social vulnerability had a 3 times mortality rate from those that were in the top 20%, so had the least social vulnerability. Again, at the block level, you can see that you can come in and identify areas that are very low or low risk, and right across the street's an area that's extremely high risk for mortality. And you can see that some of that risk is associated with their proximity to hospitals, healthcare, and then food sources. And when we start presenting this information, we get questions about, do you know that it's valid? You don't have enough COVID-19 data. So we built this off of a surrogate of, again, flu and communicable infection and poor outcomes. And then we pulled it back to the census tract information. So using a bunch of inference techniques, we were able to just take the inputs that you can get from every census block, population density, median income, environmental health hazards, stuff you can get from HUD, EPA, the census tract, and just use those as the predictors into the risk to understand, what is the relative risk of these block groups and communities against flu and other communicable diseases. So what's really important is this working for COVID-19? So if you dig into the data being provided by New York City, there are over 50,000 cases that you can dig into. We have identified through our vulnerability, that the 5 boroughs are all either low or very low vulnerability compared to other areas. Brooklyn, I believe, is the one that's very low. But the one that is very low actually currently has a 28% lower mortality than the one that is low. So when we went through and did an analysis, the mortality rate for 329 based upon detected cases and reported deaths, which clearly is a little bit off from full infection. But when we did that analysis that we think is pretty consistent across the 5 boroughs, the mortality rate in the very low area was 1.4%. The mortality rate in the low areas was 1.8%. So we did get validation there. We also did, I live in Jackson, Mississippi, so I validated I validated Mississippi yesterday on the 329 data. There we are seeing the 3x mortality rate. So if you look at the 25% of cases that are in the lowest risk areas compared to the 25% that are in the highest risk areas, there is currently a 3x higher mortality rate based upon detected cases and reported deaths. So we are seeing validation in this risk across COVID-19. Clearly, that data is still in flux. It's still more coming in. There's lags. There's lots of problems, and the detection and death data is very dirty across the country. But from the validation we're able to do today, yes, these gradations do look like they are valid, at least in their relative nature. But we also get questions about vulnerable populations. Are you actually able to pick up information about prisoners? So based upon the census block level, most prisons actually come up as a census block, or several do anyway. So we dug into San Quentin, that houses almost 4,000 inmates on 400 acres. They were extremely high risk. We dug into Rikers Island, that houses 10,000 inmates on 400 acres. They were also extremely high risk. If you dig into Lewisburg Penitentiary, that has 1,400 inmates on 1,000 acres, and 600 of those are actually outside the wall of the prison in a prison camp. They're actually at elevated risk, but they're at a medium risk. So the methodology that we're using does detect the risk in prisons, but also is able to gradate the risk based upon the density in that prison and the likelihood that they're crowded. Another group that we got questions about was how do we do with homeless. So if you dig into Los Angeles at a county level, you'll see that the county is at low risk, but it's known to have one of the highest areas of homelessness in the Central City East area. And when you dig into the Central City East area, you can see that becomes an extremely high risk area. So even given the problems with using the data that we have, we are able to pick vulnerable populations with regard to homelessness and prison populations from what we've seen and been able to validate. So again, this is designed to be used for health systems and governments and public health departments to help with the planning and make sure that you have plans for high vulnerable areas to hopefully reduce that disparity in infection and complications and death that we saw with H1N1. After we completed this work and we had our understanding of our ability to do this risk stratification, we dug in with our clients and produced a actual patient list, a COVID prevention list, as we're referring to it. And we're able to rank order the patients at highest risk for hospitalization or mortality if they contract COVID-19. Of note, when we're doing this analysis, of course, age and chronic diseases do play in a role, but we find a lot of people under the age of 65 that are adding risk. We find a lot of people over the age of 65 that are in relatively good health that appear to be in lower risk. So it's a much less of a blunt instrument in determining who you really should target for strong self-isolation. So what our clients are doing with this, they're reaching out by phone call, they're reaching out by patient relationship management systems via text, and they're advising these high-risk patients to minimize personal contact, minimize the social interactions, don't go shopping themselves, don't have visitors, really even family come in, get your medical care done via telehealth if you can. We've got health systems working on prescription drop-offs to make sure that patients that are self-isolating with CHF and COPD have their medication, and good instructions about when and where to get tested, how to manage home visits, and really how do we help these vulnerable patients not get a untreatable disease, and how do we do primary prevention and identifying a group that really needs to focus on primary prevention. It's been very interesting with our clients to see how they're using this. They're pulling nurses from their ambulatory surgical centers that are closed to do these calls. A number of our clients have had a downtick in the number of patients coming into clinic because of social distancing. So they have clinic nurses that are having not necessarily half days, but having downtime during the day because there's less patients coming in. So they're having them pick up the phone and call these patients. But we're seeing this as a very valuable tool to keep the highest risk patients out of the hospital and out of harm's way. There's reports that the highest risk patients have mortality of 8 to 9%. So if you're talking about the ability to make 10 phone calls and prevent an infection, or make 100 phone calls, you're probably saving a life making 100 phone calls if you can get 10 of them to not be infected because of those phone calls. So we've had a very positive response to this, and we feel like this is a really good use of AI to respond to a primary prevention crisis. We do have a couple of our health systems that are now combining the work we've done in the map and the work that we've done with this patient list, and wanting to understand who are the high risk patients living in the highest risk area, and matching those two up for additional action. So with that, I think we've got about 15 minutes left for questions, and I've seen a couple questions come in. So AJ, I'll let you take this part away.
Thanks very much, John. Thank you, ShiSh. It was a very good presentation. And yes, absolutely, we've got quite a lot of questions to try and work through. Again, I do apologize if we don't get to your question at the end or during this session. We will be following up with you all on email afterwards, just to make sure that you do get a question, do get an answer to your question. So as this was submitted very early, one of the first questions we got through, Again, I'll leave it up to you to decide sort of who to answer. But the question is, how much will the current situation speed up the use of AI within healthcare, or do you believe it won't affect it at all?
I'll answer, and then I'll let ShiSh answer as well, because I think it's also going to speed up the location intelligence geospatial aspect as well. I do think this is going to speed up the use of AI. There's clearly been a good response from the analytics community to COVID-19, trying to help, whether that's the Chime model or actnow.org, trying to do surge predictions in areas, Jvions, patient level list or community vulnerability map. There's been a response to this, but what I think is most glaring is how much we don't have that we wish we do have, and how I do expect that this is going to speed the use and adoption of AI as this crisis begins to settle down a little bit.
Yeah, and I kind of see a huge uptake on location intelligence and a combination of AI as well, mainly because there is a lot of data, and that data is really valuable fuel for really understanding how do we make the right decisions and make it quickly enough. And many of the healthcare agencies are realizing that today, compared to many years ago, there's a lot more data, and there is tools that make it very easy to use the data. And as a result, that combination is really accelerating the use of AI and location technologies.
Okay, and this next question is to John. Could you say a few words about the move from predictive to prescriptive, and why, outside of alert fatigue, you prefer taking the prescriptive approach, especially given the tough regulatory strategy required?
Sure. So I think for a long time we were looking for the perfect solution, the perfect accuracy, and we understand that when we're in healthcare, we're dealing with patients. It's probably never going to be perfect. We're never going to have the perfect data set, but we can have impact. Over time, but if we use the right techniques and take the right approach, we can have an impact right now. The regulatory framework with the FDA, they're still putting guidance out there, and exactly where the lines are going to fall are unclear, but the guidance is pretty good. And it's very clear that, if you're looking at informing clinicians' decision-making as opposed to driving it, and you're able to do it in a non-black box manner, the FDA is going to have you as clinical decision support. And we think that with the right AI techniques, it's pretty easy to land in the non-black box, an interpretable type algorithm where clinicians know why a recommendation or decision was made, as well as not directly driving their care. So that piece, we think is very promising for AI. There's going to be a lot of AI that fits in the clinical decision support space. But we also expect that the frameworks that they're coming out with are where they do want to either regulate the companies or regulate the higher risk technologies. They seem like they're going to be pretty straightforward paths to get approved. We're seeing increasing numbers of devices using AI get approved. So we think that process is going to be relatively smooth compared to other FDA regulatory approvals, namely medications. So we think that this is going to be something that we can work within, although at this point Jvion is focused on meeting the criteria for a clinical decision support tool.
Okay, cool. And I think this one I'll direct to ShiSh. How would a traditional top-down organization like the CDC leverage distributed, potentially crowdsourced tools like this?
And I'm trying to think of what crowdsourced tools. There's crowdsourced data, and then the tools that we have really is something that if a CDC, for example, wants to use this, the way they would use it is, one, for doing the analysis itself that'll support the decisions they make. So all of the data is assisting in better understanding what's going on, and combined with predictive analytics, it is really enabling CDC and other agencies really to see what's going to happen. Once that is established, the tools like Azure Maps can be used not only for doing the analysis, but also doing the communication for the action. So what's the action to be taken as a result of what was predicted, what kind of actions, what resources need to be assigned to various places, situations, all of that. So it is a combination of really the analysis, the prediction, the communication, and then integrating it with workflow capabilities to be able to drive what do we do with this. And that's really one of the ways that agencies like the CDC can make use of this.
And John, do you have anything to add?
Yeah, I mean, so I think from the groups that we've been talking to, even prioritization planning is difficult. So whether it's the CDC or a community food bank, knowing where the impactable communities are can be really powerful. So if you're something like the Atlanta Food Bank that has 750 pantries, and you need to get to them before the shelter-in-place order comes in place or the surge hits that area, they can't call all 750 pantries in a single day. So how do you prioritize, where that is? And they've got good geospatial analytics, so they can combine that with something like the community vulnerability map and find that overlay and say, okay, these are the 25 pantries we're going to call today. These are the 25 pantries we're going to call tomorrow. Based upon where they can have the highest impact. And I think that's from the CDC perspective. It really is focused on what are the analytics that lets you find out where the modifiable risk is, not just where the highest risk is.
Okay, cool. And I think this is another one for John. Hang on, I've lost it on my list here. So how would you predict specific trajectories in the absence of data? So an example here is, if I want to predict cardiovascular disease risk trajectories in COVID-19, can we combine modeling for COVID-19 outcomes and CVD outcomes? without COVID and estimate what trajectories might look like if we combine models in patient subgroups?
Yes. So in the absence of data to this means in the absence of COVID-19 outcome data, right? I mean, you can't really calculate trajectories in the absence of data in general. But so the Jvion Core AI has 3 million patients in it that we understand, and we understand the trajectory of I'm sorry, 30 million, not 3. Understand the trajectory of 30 million patients. So we're able to take a combination of cardiovascular outcomes, CHF outcomes, acute MI outcomes, trajectories, and overlay those trajectories with flu, parainfluenza, pneumonia. Pick your surrogates and overlay those trajectories and come up with an estimate of what we think the trajectory for COVID-19 would be. Cross-check that with the information that we have coming out of China, coming out of Italy with regard to cardiovascular events, the contribution of age and chronic diseases to outcomes, make sure that they line up with the existing literature. So that would be our approach, is to overlay the trajectories of surrogates that we understand well, make sure that those conclusions do match up to the limited data we have about COVID-19, and then move forward with a forward learning technique. So as COVID-19 data comes in, we revalidate that we've made the right predictions and have calculated the trajectories correctly.
Okay, and ShiSh, could you look to provide like a practical example of something that could be rolled out to the public to detect, treat, and mitigate disease? The audience would like you to kind of relate it to the current COVID pandemic. You're still muted, ShiSh. Hang on.
Okay, sorry.
There we go.
Yeah, one of the areas that we were looking at from how do we roll out tools to help mitigate is really looking at examples that I talked about, really understanding the impact of measures that are in place today and determining is that working out, rolling it out across different places. So for example, understanding spatially, if there's certain measures being applied in certain cities and we see a correlated improvement in the situation, applying that across multiple places. Physical distancing, social distancing was one of the examples that I talked about, where we can, using the tools, determine is that really working? Are we seeing an improvement in cities where we are seeing physical distancing being practiced? And once we see a positive result in that, we can then use that as a decision point. And that was one of the ways that we can use that data to really better understand the impact and then use that. John, you got anything to add to that? Yeah. Super.
Yeah, no, I mean, I think there's enough going on regionally, enough regional differences that if you start looking at the event tracing, the mortality rate at a more granular level, you can certainly understand the impact that it appears to have had with Mardi Gras in New Orleans, and knowing, and I'm sure you guys have this as well, when whatever the opposite of social distancing is, when everyone descends on a city for Mardi Gras and then watch the watch the tracing and spread of the disease, you can. It's a little harder to see right now, but if you looked at some of the national maps, you could actually see the spread go up Route 55 from New Orleans up to Memphis, and you could absolutely tell that there were clearly people that came from New Orleans and went up to Memphis and up to Arkansas that were spreading the infection.
Yep.
And if you watch that day by day, you just saw it get more and more filled in after Mardi Gras, about 14 days after Mardi Gras.
Yep. Okay. Well, I think we've got time for just to squeeze in one last question, and I think I'll put this one to you first, John. So they've asked that, they said that, hey, I'm a surgeon, and my impression is that the crux of these expert systems is based on the assumption that they are employed to perform the analysis. Now, is there an example where AI has led to new insights into the diagnosis and/or treatment of disease?
Sure. So they are certainly hypothesis generating as well. So again, if it's a black box and you don't understand why the decisions are being made, they really don't help with the new discoveries. But if you do use techniques and have an understanding of what the contributing factors are, you certainly can, come up with new hypotheses that need to be tested. And we work with our partners. One of the things that we've seen with regard to severe infections, sepsis is actually cataracts. There's a known association between low vision and an increased risk of hospitalization for infection, which would then clearly track to, possibly having a worse infection once you're in the hospital. But there's actually, very little data about whether or not, cataracts actually are a part of that, and whether or not having cataract surgery would reduce your risk for sepsis. That's an unanswered question, but it's certainly one of the hypotheses that we've generated, and we're doing a number of research projects with our academic clients, to do deeper dives and investigations into things that we're seeing coming out of the AI. But again, it comes back to using techniques that focus on understanding what the risk factors are and understanding if those are modifiable risk factors to really generate new knowledge. I wouldn't necessarily say that they're ever, evidence in and of themselves, but there certainly are, increased knowledge that can be further studied coming out of AI.
And ShiSh, do you want to add anything to add?
Yeah, the only thing I would add to it is really the transparency of the model is, I think, the most important thing. Taking all of the influencers that you apply to the model, knowing all of them, having that transparency, I think, will really, it will help people understand what is influencing it or how the model was built. I think the black box models are really a challenge to work with.
Okay, brilliant. Well, unfortunately, that is all we've got time for. Do apologize if we didn't get around to your question today. As I say, we will be sending out personal emails to everybody to answer your question. But again, big thank you, John. Thank you, ShiSh, for kind of taking the time to present to us. It was very informative. Very much appreciate it.
Thank you very much.
Thank you
very much.
Bye.